Okay, one more person's coming in. Okay. Hi, everybody. I'm Paula Heller Garland. I'm a senior lecturer and the coordinator for the Addiction Studies program at the University of North Texas. And I'm also the PI for the Recovery to Practice initiative here. And that's who's bringing you this webinar for free today. I'm excited for this topic because Dr. Sharma visits Portugal and is going to be able to give us an update on her last visit just this summer. And during Recovery Month, we hope to see all of you at some of the recovery rallies that are traveling throughout Texas this month. And we'll be hosting one more webinar after today. And then the last Wednesday of the month, we will host an in-person symposium with a couple of speakers on campus, but we'll also have an availability to do that online. So you won't miss out if you can't get over here to Denton. And we also have more information about everything that we do on our website, our social media pages, and our groups, and on our periodic newsletters. You can keep up with all the things that Recovery to Practice does through our public Facebook page or by joining our private virtual community of practice that's on Facebook. And I'll drop the links in the chat box in just a moment. But before I introduce the presenter, I want to do a couple of housekeeping things. First, if you would like to receive the free 1-hour continuing education unit for this webinar, or you just want a certificate saying that you attended, please drop your name, first and last name, and your email address in the chat box right now. And before the end of the webinar, I will send you 2 links. The first one will be for a SAMHSA survey, and we encourage everyone to complete that, even if you don't want a certificate, because SAMHSA is who helps fund our program to bring you these webinars. And the second link will be for this particular webinar for the feedback. We really value that for what Recovery to Practice brings to you. And it also requires for the continuing education that we have you fill out the word is escaping me, an evaluation to get the certificate of completion with the continuing education. So about 10 minutes before we end, we will have a Q&A, and I will take questions in the chat, or at that time, Dr. Sharma will let you know how she would like to interact with you. So I am going to turn it over. Dr. Sharma is an amazing professor. She's been here about as long as I have at UNT. She's also the chair of our department, an amazing team leader, and just can't wait to hear what she has to share with us today about all the wonderful things going on in Portugal. Dr. Sharma?
Thank you, Professor Paula Garland. I appreciate the invitation to come chat with the attendees about one of my favorite countries and one of my favorite harm reduction programs. So thank you. And thanks to all the attendees for taking the time to be here today. I can talk a lot about Portugal. It's a country, as Professor Paula Garland mentioned, that I've had the opportunity to visit quite a few times since 2017, up to my most recent trip earlier this year over the summer. And I continue to learn a lot more about the way that they have implemented harm reduction and then followed through on tracking the outcomes of those approaches over the past over 2 decades at this point. So we'll walk and talk through this presentation. We're going to start by just talking, or I'll talk about harm reduction as a whole. So we're on the same page in terms of what we're talking about when we talk about harm reduction. And then we'll dive more into looking at Portugal. We'll talk a little bit about CCOD, which is their directorate for drug interactions and addictions, kind of the equivalent of SAMHSA in Portugal. And then we'll talk about a very specific geographical region called Castelo Ventoso in Portugal that was at one point known as Europe's drug supermarket, because of the number of drug transactions that happen there every day and how the government addressed that particular location. And then we'll wrap it up with talking about some NGOs, nonprofit, non-governmental agencies that work with individuals who are using but would like to use in a safe manner. So without further ado, let's start by talking about what harm reduction is. It's a term that is often used in the context of global health policy. And while there's no one definition for it, we look at it holistically as an approach that attempts to reduce the adverse or the negative health, social, and economic consequences of drug use while a person is still using. Now, harm reduction doesn't just apply to using drugs. It could apply to alcohol or other substances as well. In this context, of course, we're looking at it from a drug use approach. The focus in harm reduction is on keeping the person safe and minimizing the negative consequences of higher risk behaviors, such as in Portugal's case, looking at substance use, actual drug use that people were engaging in. So while there is no universal definition or formula for implementing harm reduction, it really depends on looking and assessing the individual needs of the person in that culture in that particular time frame. So while I'll share with you a lot about what Portugal has done, harm reduction in Portugal may look vastly different than harm reduction in another country. For example, Thailand. I got an opportunity to visit Thailand last year and learn about how they have implemented harm reduction. It looks quite different, but for Thailand, their approach makes sense. And for Portugal, their approach makes sense because you also keep in mind the socio-political climate, the access to healthcare services that are present in the country, and other cultural nuances that impact the buy-in that community members have about newer initiatives or approaches being launched. So when we talk about harm reduction in the context of drug use, the main assumption is that drugs can cause real harms, okay? And these harms can fall into many different categories. They could be psychological in the way that they impact the individual's, current functioning. It could cause a lot of trauma, mental health symptoms. They can also be physical, right? Made real by actual physical injury to the body, depending on the mode of administration. They could also be social, legal, or economic, right? They could impact a person's job, their livelihood, their ability to be in a home, pay rent, their relationships with family members or friends, and of course, interactions with law enforcement in that process. And these harms are not just limited to that one person who's using. They also extend to the family, the community, and society as a whole in which that individual operates. So when we look at harm reduction from this very holistic view, we realize it's not something that is just for one person. It actually has a positive consequence on the entire community and society in which that individual operates. And with harm reduction is this other main idea that harms are not an inevitable consequence of drug use. In other words, in theory, a person could choose to use but also not experience psychological, physical, social, legal, or economic harms that come along with it. They are an inadvertent side effect, if you might use that word in this context, of the drug use. So in that case, with harm reduction, we believe that harms can be prevented or reduced possibly through a range of different strategies. And this is what we'll talk a lot about. So let's look at a quick overview of harm reduction, right? We place harmful consequences of drug use on a continuum. And if this continuum goes from no use on the left, that bluish area, to what would classify as a substance use disorder on the right-hand side, the goal of harm reduction is to move along this continuum from right to left, right? So taking steps to reduce the harm. If a person is perhaps in the bright red area, getting them to move into maybe the orangish area would be considered harm reduction, or getting them to move from that orangish area to maybe more of the yellowish, greenish area is also harm reduction, as is getting someone to go all the way to the bluish area where there's no use at all happening. All of those are different types of harm reduction. So on a continuum, we can see drug use going from no use to really chaotic use, right? And any step that we take, reducing a person's inevitable harms associated with drug use so that maybe that chaotic or compulsive or chronic use is also not impacting their relationships or their ability to hold down a job or have a roof over their head, are going to be positive effects of harm reduction in use. I should have warned you guys that my lights go off in my office pretty frequently. So If you see me looking ghostly white, it's because my lights have turned off, and I just need to wave to get them back on again. Okay, so here are some central assumptions of harm reduction. It looks at drug use and drug use prevention methods as public health alternatives to what have often been moral, criminal, and disease models of drug use and addiction. Here in the US, we use a very moral, criminal, and disease. We've used the disease model here quite a lot as well. So this is why often you'll hear people say, well, that person is choosing to use a drug. It's their choice. They should make better choices. They belong in jail. Okay. And so people bring in their own personal morals into this instead of looking at it as a larger public health alternative or a public health problem. So the way that we looked at something like the COVID pandemic, right, where we said it's not just about the one person, it's also about the community. We didn't blame people when they got COVID. We provided them with safer ways to live in those months, those first few months, so that they could lower the possibility of getting COVID and getting impacted by it, whether on a very serious scale or even on a milder scale. There is a recognition, and sometimes this gets overlooked. There is a recognition in harm reduction that abstinence is an ideal outcome. I mean, if we can get a client to move all the way to no use at all, that's ideal. But we also accept other alternatives, right? So it's this concept of multiple pathways to recovery. Your pathway doesn't always have to be black or white, where either you're using or you're not using. But if you're gradually reducing use or using in a safer manner, that is also a good path moving towards recovery, with the ideal goal that at some point there will be no use at all. There's a lot of value placed in partnering with different groups in agencies and the individuals to obtain input on programs pertaining to harm reduction. So I like this quote by Mark Twain, which I don't think he realized this, but I think it applies very well to harm reduction. It says, habit is habit, not to be flung out of the window by any man, but coaxed downstairs a step at a time. And I think this speaks a lot to the tiered approach that harm reduction carries with it, right? If you have someone who's at an increased risk, they're using excessively, then maybe just getting them down one step can make a pretty significant difference in their quality of life overall. And then maybe another month, another year, another 10 years, we get them down another step or another 2 steps. Those gradual steps are what lead to sustainable recovery, as opposed to putting someone in inpatient treatment. They're there for a month in a very artificial environment where they have no access to drugs, so they cannot use them. But then they're out in the community, and it's not uncommon then for individuals to come right back into treatment center, right? We often talk about the doors of treatment centers to be revolving doors, where a person goes out and then a couple of days, weeks, months later, they're back in again, because that recovery was not sustainable because of the way in which it was done within a month or 5 weeks or whatever insurance allowed the treatment center to pay for it. So any steps towards decreased risk are steps in the right direction as far as harm reduction is concerned. There are a couple of different tenets of harm reduction. One of them is respect, very non-judgmental understanding of each individual, where they are at in that process. There's also an acceptance that substance use is not as simple as using or not using. It's a very complex, multifaceted phenomena. Individuals don't typically start using drugs because they think it's a great idea that's going to make their life better. They oftentimes are using drugs as either a way to escape a reality that they just feel they don't have enough strength to navigate, or maybe they're overwhelmed by it. Maybe they're coming from really traumatized backgrounds, and they just are using those drugs to self-medicate, right? So it's not just as simple as using or not using. There are a lot of different layers to it, and we accept that. There's also empowerment of the individual. We see the individual as a primary change agent instead of forcing them to make a change that they're not ready for. There's also compassion. That's a big part of harm reduction. We're looking at the true realities of things like social isolation, trauma, discrimination, social inequalities, and vulnerabilities on that individual. So if that person is struggling and then we add on these other things, there's discrimination, they cannot get hired for a job, They're not able to find low-income housing in a proper neighborhood where they can be away from possible drug interactions or drug trafficking that's going on. Or they continue to be in an environment that is extremely traumatizing to them, and their friend or family have stopped talking to them. All of those things are very strong indicators of potential of relapse, because those put a lot of pressure on the person. And so we try to stay attuned in harm reduction to that, and approach it with a lot of compassion. And then there's collaboration, right? We want to have an open dialogue, share information, and support the individuals in developing and implementing strategies that work for them. We let them be the change expert. Remember, they get to decide, I think I can do this, instead of us saying, this is what you need to do. All we can do is be the facilitators of change by providing opportunities, but then allow the individual to select the ones that are personally meaningful to them. So here are some, potential goals for harm reduction, especially in the case of Portugal. They looked at reducing the spread of infections such as HIV and Hep C, because the rate of contamination is really high when you're reusing and sharing needles that a person who's infected with either the Hep C or the HIV virus could then pass on to others. We're also looking at reducing risky drug use. So not reducing drug use, but reducing risky drug use. And we'll talk a little bit about the distinction between those two in a little bit. For Portugal, a big goal for them was reducing the drug overdose deaths. I'll talk a little bit about caso ventoso, and when I do, we'll talk about how the drug OD deaths were off the charts. They were the highest at that time for Portugal of any nation in the world. And that was a very real threat to society and the people, and it was a very, very prominent goal for them. They also focus on providing honest drug education. So none of this whole DARE program, right, which had millions of federal dollars funded into it, only then to find out 10 years later, it actually did nothing at all to reduce drug use or substance use in general, because the information that was provided was not honest drug education. It was all very abstinence focused, say no, say no, say no. But then kids hear about other things which make them want to say yes, right? So we have to have honest communication with drug education so that it allows for a dialogue and an exchange. And we want to increase the user's contact with services and treatment. You could build the most amazing, best resource, best treatment center, but if the person who needs it does not know about it, there's a very good chance they're not going to find their way to that place all on their own. So there are different methods of engaging in harm reduction. These could include things like safer route of drug administration, maybe using an alternative, safer substance, such as maybe a methadone replacement instead of using heroin, reducing how often the drug is used, the frequency of the drug, reducing the intensity, how strong the potency of the drug, or just reducing other harmful consequences of drug use. And all of these changes, the behavior change happens along 3 tiers. It happens at the individual level. It also needs to happen at the environmental level, right? The community that the person lives in also has to change their behaviors and how they approach individuals who are using drugs, right? If you look at them and you look at them in disgust, and there's a strong stigma that's around the community, then it's going to make it that much harder for the individual to see themselves being a meaningful part of that community. And then it doesn't stop there. The change also has to happen at the policy level. Those of you who work in treatment centers know very well that what you can or cannot provide in terms of treatment options are severely limited by policy, whether it's policies coming from the insurance companies or just larger policies in the US that govern treatment options that can be provided to the individual. So policies trickle down to the actual services that the individuals are able to receive. So with harm reduction, we're looking at giving control back to the person. And this can happen in a variety of different ways, right? These are small steps that can allow the person to reduce the harm to themselves or others. So a very low-hanging fruit there is encouraging a user to know their dealer so that they can establish the source, the strength, and the toxicity of the drug. they're not just buying from whoever who could possibly sell them, something that's laced with something that they were not expecting. Those of you, well, actually, I'm sure all of you are familiar with the fentanyl crisis that we're having right now in the US. And with the vast number of reports of fentanyl overdose deaths, it's not always that the person knew they were taking fentanyl. It's the fentanyl poisoning as opposed to the fentanyl overdose that has been a big problem, right? Someone thought they were taking a different substance without realizing it was laced with fentanyl, which has led to their body going into cardiac arrest and shutting down immediately within like minutes of consuming the drugs. So knowing the toxicity strength and the source is a very low-hanging fruit there. Maybe, ideally reducing the amount of drugs consumed or avoiding using alone. So in case there is an adverse health reaction, there's someone there who can quickly call 911 or, a medical provider and ensure that you are able to receive the life-saving support that you may need at that time. It could also be something as simple as using a different vein every time and not just using the same vein repeatedly, which then often leads to collapsed veins, right, which are causing a health consequence that is then that is not an inadvertible consequence of using that drug, right? So just knowing to alternate veins, so you're giving your vein a little bit of a break, so to speak. Using sharp rigs, water spoons, cotton needles, syringes, of course, disposing off used needles, learning CPR, considering substitutes such as methadone, and even practicing safer sex to prevent the spread of infection, especially as it pertains to things like HIV and Hep C. So there could be various community-related harm reduction strategies. Here are 3 examples. So most of you are probably familiar with needle exchange programs. And actually in Portugal, when I first went in 2017, they had a needle exchange program where the community workers would go out into the community where they knew drug use was happening. They had these little buckets where a person could put in a used needle and in exchange get a clean needle, right? But then they found, when I went most recently in 2023, they shared with us that they'd actually altered that just a little bit so that it wasn't really an exchange, because they found that sometimes when people did not have I guess clean or needles, because they just kind of thrown them away and didn't care to like hold on to them, then they also didn't feel like coming forward to get clean syringes and needles. So it was actually preventing them from using the clean needle supplies that the community workers were providing. So now it's, they've reduced the judgment even further and said, you don't have to provide us with a used needle, we'll still provide you with clean needles and syringes, just come and get them. So I thought that was pretty cool to see that they were responding to how the program was working and then use that data to further inform how they would continue that program moving forward. There can also be methadone maintenance treatments. Portugal provides these. They truly believe that methadone saves lives, and the government is able to provide for the costs associated with methadone replacement for life for a person who chooses to use methadone instead of using heroin. Because with methadone, they can take methadone, and we'll talk a little bit about methadone vans that go around the communities in Lisbon. So the individual could come, get their dosage of methadone from a nurse, go to work, spend their day at work, earn a livelihood, come back home, and then repeat the cycle. Instead of using heroin and then not being able to go into work, losing their job, not having a place to live because they cannot afford rent, missing out on relationships, right? So that's another harm reduction strategy that has worked really well in Portugal, as has their various outreach models, where, as I was mentioning earlier, they've got community workers that go out into the community to interact and build sustainable relationships with the users, to share with them different resources, different paraphernalia for drug use. So they're engaging in safe use if they're doing so. So a little bit about Portugal, where really I've over the years gotten a chance to see harm reduction in action. Portugal is this little country that often gets forgotten in Europe. I'm trying to find my laser pointer so I can point out. Okay, there we go. I think there we go. So there's Portugal right there, right? Everything to the east of Portugal is just going to be water, 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 tons of water. Okay. So Portugal, then when you look at it zoomed in, it's pretty much a long country, kind of like California in terms of the shape of it. You've got Lisbon, which is the biggest city. It's a capital city in Portugal. The second big city is Porto. Porto is up north in Portugal. And then you've got kind of the central part of Portugal where it's a lot of rural areas. Most of the urbanism is around Lisbon and Porto. That's it is. Portugal is a beautiful country. This is a picture of Porto. It's a river Gaia with Porto on the right side and then the city of Baixa on the left side. Gorgeous views. This is a view of Lisbon. This is the downtown, old downtown area, colorful buildings, rolling hills. You can see the river Tagus in the back over there a little bit. Here's a picture of Sintra. It's the Palace of Pena. The city of Sintra is known as the UNESCO World Heritage Site. There are just all these gorgeous historic places there. Tons of beauty, both, of course, in the palace itself, but also the neighboring views that you see of Cascais, which is the fisherman's village, which has grown a lot since then. Lots of good surfing, lots of great food. Portugal is also known for port. So if you've heard of port wine comes from Portugal, and in particular, or specifically, it comes from Porto. Porto is the city I was telling you, that's the second largest city in the northernmost part of Portugal. So for any wine to be considered port wine, it has to come from Porto. Okay. Portugal is also known for sardines. I know that's kind of laughable for some of us to think sardines, but sardines in Portugal look very different than the canned sardines that we're accustomed to. When they have a sardine festival, which I had the pleasure of being a part of this past summer, it's a month-long celebration. That's when the first of the sardines are brought in. There are barbecues set up all across city. The entire town is a big party. Like every corner you go to, there's someone who's grilling sardines. Everybody's downstairs. Somebody's playing music. Somebody's, got alcohol, and you're just out on the streets literally every day if you want to be for the entire month. Portugal is also known for tiles. The history of tiles in Portugal dates back thousands of years at this point. They started with very basic colors, and now they have these beautiful, colorful tiles that you'll see all across Portugal. So let me tell you a little bit about the story of Portugal and how they came to be in the situation that they were. In 1974, Portugal deposed of its dictatorship. So at one point, Portugal had colonized a majority of the Eastern Hemisphere. They had tons of colonies and territories, but about mid-70s, they decided they're no longer going to do that. They wanted to embrace democracy. So it was a pretty stressful time. There were a lot of animosity and feelings set up with about 40 years of totalitarian regime that Portugal had gone through at that time. So as they were decolonizing, Portugal's former colonies rose to claim their independence, and a lot of Portuguese soldiers and bureaucrats returned home, right? And I want to say the word home in quotes because for many of these Portuguese people, they had never actually even lived on Portuguese land. They had always been in the colonies. So we're not just talking first generation, we're talking second generation, third generation, even some fourth generation Portuguese people who had never been in Portugal. They had always been in the colonies. That's where their parents, grandparents, possibly even great grandparents had moved, and then the families had continued to grow there. But when decolonization happened, all of these individuals had the opportunity to move back to Portugal and start life afresh in a new country. So as you might imagine, with hundreds of thousands of people moving back, and again, I say back in quotes, because for some of them it was the first time in their lives, there was a high rate of unemployment, and I say this with a caveat, this is the Portuguese version of the story, right? They say that with this also came a lot of drug use from other nations, that the people, like that drug use might have been commonplace in other countries. And then when those decolonized people, that's not the right word to use, when people from those decolonized areas came into Portugal, they brought with them a lot of the substances that were used there. Okay. So while by the 80s, the country had greater freedom of press, speech, and justice because of democracy, they also had very heavily escalating drug use. So heroin was kind of the king of drugs, if you might say that, with about an estimated 100,000 people, which is almost 1% of the country's population at that time, that was addicted to heroin use. So this led to a crisis in by the late 80s. People were seeing people using commonly in the streets. People were seeing, people who had maybe overdosed on the streets, and it led to really this crisis, this public health epidemic within the country. And people asked the government to intervene. They said the government has to do something about this. And they felt safe with the government taking over because remember, they'd gone through 40 years of totalitarian regime where the people had no choices. They had no word or no opinions that they could share. They were just on the receiving end. And now with democracy, they said, we've elected you to be our officials. It's your responsibility to do something about this. So what did the government do? Well, they started with Dr. João Lau, who at that time was a young family practice doctor in the Algarve region in Portugal. Algarve is in the southernmost point of Portugal. Lots of rocky beaches, small fisher towns, sort of like the rural parts there. But Dr. Lau was a family practice doctor in Algarve who found that he had a lot of patients with drug addiction problems, right? And at that point, he felt there was this ethical dilemma with reporting them to the police because they had to report, the physicians had to report them to the police. But he found that he couldn't quite do so because he knew that being reported to the police, being arrested, was not going to give these people the treatment that they needed to stop using this heroin if that's what they wanted to do. So I've had the pleasure of meeting with Dr. Gulao a couple of times now on our visit. Here's a picture of me and him in 2017 when we met. And I wrote down this quote in my little book when we were chatting that day. And he said, at that time, it seemed everyone had a family or a friend with a drug habit. But these were not outsiders. They were part of our communities. They were decent people with problems, right? And I remember him very distinctly saying, these were maybe somebody's high school teacher. This was somebody's cousin. This was somebody's father. These were people in a small community that everybody knew, and we knew they weren't bad people, but they were people who had a habit of using drugs, and sending them to prison just didn't seem like it would be the right fit for them. It wouldn't provide them with the help that they need. So Dr. Gulao became quite the advocate of this in the medical sector. And now, 20 years later, he actually works as a director general of CCOD. And CCOD stands for the General Directorate for Intervention on Addictive Behaviors and Dependencies. In case you're wondering why the acronym doesn't fit the words, because this really made me go a little bit, it made me a little confused. It's because the acronym is in the Portuguese words, right? So whatever the title is in Portuguese is where the acronym comes from. So CCOD currently operates under the Ministry of Health, and Dr. Gulao joined this government task force that was searching for a way forward, right? So we're in the 90s at that time. He, along with this task force, traveled to many different countries around the world to look at their innovative drug policies. They studied theoretical models, consulted with professionals in the field, and they came up with a plan. And this plan, which eventually became law, changed the categorization of drug users. So instead of looking at them as being criminals who needed to be punished, they were now looked at sick community members who needed help, right? So it went from being, again, that criminal approach to a public health approach, right? If you think about something like the AIDS pandemic, right? We did not think of AIDS, someone who got AIDS, as being a criminal. It was someone who was a patient who needed help, who needed medicine, who needed vaccines or cures for it at that point. And that was the main shift that really led to a lot of changes that have occurred over the years in Portugal. So Portugal then took this very revolutionary step at that time of decriminalizing all drug use, okay? Everything from marijuana through heroin, and it became the first country to do so in the world. And it's important to clarify that decriminalization is not the same as legalization. Okay, the two terms are often used interchangeably, but they are not. Decriminalization does not mean legalizing the use of substances. Drug use is still illegal in Portugal. It is just not considered a crime. Okay, so it's based on the premise that it is possible to rehabilitate drug users outside the criminal system. And when Portugal implemented decriminalization, there was an outcry from really around the world where people were saying, wow, you're going to decriminalize drug use? Well, your drug use is going to increase because if you tell people it's not a problem, then what's going to keep them from doing this, right? But over the years and over really the past 2.5 decades now, we found that decriminalize does not increase drug use, especially as we found in the case of Portugal, their drug use numbers have gone down considerably. And what's the right word? I want to say chronically, but that's not the right word. But like they've continued to go down from the 90s up to where we are right now. That's not to say there haven't been some occasional increases, but it's been a general negative trend in terms of drug usage. Now, decriminalization was the right approach for Portugal at that time instead of legalization because of one very key factor. Portugal, as I've mentioned, is in Europe. It was part of the European Union. It still is. And as part of the European Union policies, legalization is not an option. Okay, so Portugal decided, okay, we cannot legalize drug use. We can still decriminalize it so that using a drug is not a crime. Selling a drug is still a crime and is punishable by the highest level allowed by law. So in order to get buy-in for decriminalization in the community, I thought the government took a really clever step, which was to actually get buy-in from the Catholic Church, so that majority of Portuguese who are Catholics, I think the rate of individuals who self-identify as being Catholics in Portugal is between 85 to 90%, right? When you get buy-in from the Catholic Church, and the church, the Pope says, this is a way that we are going to make a difference here in the lives of people, then you're going to get buy-in from the community as well. So as I mentioned, drugs are and remain illegal in Portugal. So in theory, anyone using can and will likely be picked up by the police. However, here's what's unique. Instead of being sent to a criminal court, offenders are given 3 days to present themselves before one of their dissuasion commission hearings. This is one of the health ministry's special panels comprised of psychologists, doctors, social workers, and judges. The panel then evaluates each case and makes recommendations. So anyone who's found with a quantity which they have predetermined is, quote, reasonable for 10 days of personal use. These are predetermined levels for each substance, so they're different for every substance. But if it's about 10 days of use, then that person they basically get the equivalent of a traffic citation. Okay, so they're not sent into prison. But if the quantity is more than that, then they can be sent into the criminal justice system, where they can be and are prosecuted and punished for drug trafficking. Okay, but there is a difference made between, quote, addicts and casual users. So those that are determined to be casual users are let off with a warning, maybe a fine, but it's not a hefty fine. We're looking at maybe about 50 to 60 euros. If the person is unable to pay it, it doesn't keep going up. It becomes like a $500 fine, the way, you know, our speeding tickets here in the US do. The person can usually get it waived if they show that there is financial duress, they're not able to pay it. But people who are determined based on their usage and the amount that they are seized with, as they're determined to be addicted to heroin, they are then directed to one of the country's treatment centers where they can get help for reducing use or stopping use entirely. They could get counseling, they could get methadone replacement treatment, all at no charge to them. The government covers the cost of treatment for them. So you might think to yourself, well, like, how does this work then? I mean, you tell people it's not a big deal. They only get a citation if they get a citation at all. And even with that, if they don't pay it, they're not in more trouble for not paying it. They don't, like, I don't know how this works. Well, it works because when you offer people the resources and options and you're non-punitive in that approach, the person comes to those resources when they're ready to engage in it. That may not be today, it may not be tomorrow, it may not even be the end of this year or next year, but eventually, when that person is ready to stop using or to reduce use, they know exactly where to go. And that internal motivation to make the change is heightened in that person. They are ready to make that change and can now go in and make use of those services. If it seems like a big deal, it is. So here's a quote from Caitlin Hughes, who was at that time the president of the Australian National Drug and Alcohol Research Centre. She says, what was unique was that for the first time ever, there was a focus on the rights of drug users. That and a willingness to take a risk, even if it was unclear that it would work, right? So we weren't saying, we, the government, are going to tell you, the user, to stop using because it's wrong. We were saying, okay, everybody has a right to do whatever they want in their life. You have a right to use drugs if you would like. Here are some resources and treatment options that we can offer to you in hopes that it would work when you're ready for it. Okay, and that was big because it had never been that approach before Portugal adopted it. So CPAD currently promotes a lot of education on drug use. They support the Ministry of Health. They develop, promote, and foster research. They keep updated information. They also work very closely with MCDDA, which is the European Monitoring Center on Drugs and Drug Addiction. MCDDA's main office is actually in Lisbon because they felt that Lisbon, with all of their harm reduction initiatives, was an excellent place to have the headquarters of the European Monitoring Center on Drugs and Drug Addiction. And CCAD also ensures cooperation with a lot of national and international bodies, such as Europol and Interpol when it comes to drug, alcohol, and drug addiction. So they engage in a lot of interventions, such as prevention, dissuasion, risk and harm reduction, treatment, and reintegration. They also keep updated numbers of drug usage patterns in Portugal. So every time when we go visit with them, they show us the latest rates. And again, as I mentioned, starting from 2017 to 2023, I've seen those numbers change for the better continuously. Again, some things might peak, but most things are going down. And even when they peak the next year, then they would stabilize to a lower level. So here are just some basic numbers. 80% of the costs of treatment are paid by the state. 20% of the costs are paid by the individual. However, Portugal also went through a very serious economic crisis where individuals many times could not afford even 20% of the cost. And if that was the case, then the government case managers would work with them to either find ways to fundraise for that 20% that they needed to pay, or if it was very evident that 20% was not coming from anywhere, then the government would kind of eat the cost as well and just let the person take the treatment or get the treatment when they were ready for it. They have 3 big national facilities and approximately 60 run by NGOs, non-governmental organizations, that work in tandem with the governmental organizations. So it's not a competition where it's about the money, like a lot of treatment centers in the US, charging, $5,000, $30,000 a month for treatment that goes into their pockets. This in Portugal is a model where it is government funded and then supported by nonprofits. They have across the nation about 1,600 beds available, which may not seem like a lot to us. Portugal is a much smaller, less populous country than we are. And the inpatient facilities are run by state, outpatient facilities are run by NGOs. So, as it happened, the number of Portuguese dying from ODs plunged more than 85%. Okay, there was a bit of rise after the European economic crisis. This year, when we went, they also had numbers from the pandemic. If you're familiar with the numbers here in the US, you know that they've gone up quite a lot during the pandemic. In Portugal, they saw some increases, but nothing that was too alarming to them because it's still lower than the use in all of Europe, and of course, drastically low compared to the use increase that happened in the US. Portugal's drug mortality rate is the lowest in Western Europe. It's about the 10th the rate of Britain or Denmark, and about a 50th of the latest number for the US. So if US could achieve Portugal's death rates from drugs, we would save 1 life every 10 minutes. So you think about how many minutes we have in a day and a life saved every one of those 10 minutes, we're talking considerable changes in numbers. Almost as many lives as are now lost to guns and car accidents combined could be saved if we were able to implement a system similar to what Portugal has right now. The health ministry in Portugal spends the equivalent of about $10 per citizen per year on a very successful drug policy. And when we compare it to the US, per the data that I found, the US spends about $10,000 per household, that's a household of four, which is over $1 trillion over the decades on failed drug policies that result in more than 1,000 deaths each week. And that number, these numbers are actually from about 2-ish years ago. So I know right now with the increase in fentanyl-related ODs, that number has gone up quite a lot more from there. So this next chart has a difference in drug-related deaths. You can see Portugal, and these are deaths per million people ages 15 to 64. Portugal, we're looking at 6 per million. In the United States, we're looking at a 312 per million drug-induced deaths compared to what we see in Portugal. Okay. So here's Casa Ventoso, the Europe's drug supermarket. It was kind of like a shanty town. Think about like a slum, essentially. Open pathways, people injected, dirty syringes, lots of infections. This is an old picture of what the area used to look like. So don't look at, the area up here on the hill that has a view of the mountains. Don't look at the area here either that's got these actual sturdy buildings. We're talking about the area right over here where it looks like nobody probably even lives there, but they did. This is maybe a better view of what it looks like. Very dilapidated buildings down here. Thank you. Dilapidated buildings, lots of lack of infrastructure. We're talking the lowest of the low in terms of economic or socioeconomic status. We're talking lots of people coming up and down, purchasing drugs just in the open. You could just come there and get what you needed. So they estimate there were about 5,000 people that would flock there every day to sell drugs or to buy drugs. This area had no water or electricity till the 80s. Okay. So I'll go through. Okay. So this is a speaker that we meet with in Portugal. And she talked about how these drug dealers in Casa Ventoso were not these big drug lords. These were grandmas, moms, pops, socially fragile people, many fourth-generation Portuguese peasants who had no upward social mobility, right? So they easily got arrested because they were on the ground level. They had bad relationships with cops. They did not have a lot of transferable skills for employment. This is all they could do to put food on their table. And the approach that Portugal took was if you take away users, there can be no traffickers. And so it was less punitive for the user and more to look at cutting down on, less punitive on the users so that if you can reduce users, there will be no need to sell drugs. So Portugal spent a lot of money on this. They created programs to reconstruct the area, educate people, GED programs, vocational rehabilitation program, housing programs for people who could otherwise not afford the living there. And this is what the area looks like right now. So you can see these high-rise buildings. There's still that walkway that people would go through, but much, much better area than what it used to be in the 80s. So here's some current community supports in Lisbon. They have community workers who go out in the methadone vans about 5 times daily. They take the same route. They're in the areas approximately at the same time, providing free methadone. So users know when they can come in, get their methadone treatment. They're on a registry. The nurse knows exactly what dosage to give them. They come, they take it, they walk away, they go do their job or whatever it is. And they found as they monitored the data that 87% of people stop using, even though they're not required to stop. Now, I will say not everybody does stop using, right? There are some who will use methadone replacement for life. We met with an individual who had been on methadone replacement for, 25 years then, so it must have been 30 years at this point. And she was so proud of herself. She said, when I used to use heroin, I was on the street. She was engaging in sex work to pay for drug use. She did not have any relationships with family members, friends, no job. And now she has a job. She's been able to rebuild a relationship with her children. She has a home, and she's able to do all of that on the methadone replacement. Here's a picture of the community worker with a kit for dirty syringes. Here's what the replacement kit looks like. It's got a lot of paraphernalia that they would use, including the shallow pans, sterile water. Here's a picture we took in Casa Ventosa more recently. So you can still see those kits, the used kits lying there. So that's to say people are still using, right? It's not that use has stopped entirely, but at least it is happening in a way where people are not harming themselves by using unclean syringes or needles and increasing the risk of infection. The Housing First program has no eligibility requirement. Anyone who needs a home can get a home. The government, the local governments help with ensuring there's housing available for individuals who need it. There's a 6-month mandatory visit by case manager to make sure the person's doing well. They help folks learn how to live indoors again, because many of these people have lived on the streets for years and years. There are food programs to help them learn how to cook, to get access to ingredients. Here's an agency we visit called Iuma Casa that helps people with housing first. Excellent program. I like this quote from the director there. He says, "We see them," and these are the people that are working with, "we see them like people, not like criminals." And so I like this. This is a copy of a postcard that they have that says, "Aren't we all drug users after all? Understand before you judge," right? And by that, they mean we're all addicted to something, whether it's my morning coffee that I need to have, whether it's my cell phone that I feel I need to obsessively check all the time, whether it's something else, right? It may be alcohol, it may be porn, it may be gambling. We're all addicted to something. So who are we to judge and say that person's addiction is bad, but mine is okay? Mororia is another NGO that works with people living with HIV. They have drop-in clinics that provide free medical care. The building's provided by City Hall, and then they have professionals that come in and provide medical intervention. Here's a quote from Ricardo Fuentes, who's the guy on the right here in this picture. He says, "Even if a Portuguese person cannot get rid of addiction, the government wants him to live a longer and good life," which I thought was just so powerful, right? We're not saying that because you're using drugs, you don't deserve to have a good life and the government should not invest in you. You're still a valuable member of the society, and we want you to live a good life. So I'll wrap up with this quote from Dr. Gulao. And he says, "I think harm reduction is about not giving up on people. I think it's about respecting their timings and assuming that even if someone is still using drugs, that person deserves the investment of the state in order to have a better and longer life." So that is where I will end. I'll send it back over to you, and Professor Carlin.
Thank you so much. That is amazing information. I'm so glad y'all get the opportunity to take our students there frequently.
Thank you.
So
Yeah.
I am going to do two things. One is I'm going to drop in the chat the two surveys. One's a survey for SAMHSA for information because they help us with our funding. And the second is if you want a certificate of completion or a continuing education unit. They're two separate surveys. One's an evaluation, one's a survey. And then I'm going to ask you if anyone has any questions you'd like to put in the chat. I'd be happy to read them to Dr. Sharma. But since we have a small group here, also, if you'd like to unmute and ask any questions.
Mhm.
Can I ask a question?
Yes,
Yeah.
please.
What does their prevention education in schools look like? Do you know?
Yeah. Well, I know a little bit about it because that was a question that we also asked when we visited CCOD this past summer. And they engage in developmentally appropriate, honest education. So they've got, information like they go into schools as young as elementary schools, and they're providing them with candid information on what the substances are, why people might choose to use them. They're talking not just about the detrimental effects of the drugs, but they're also talking about maybe some of the euphoria, the kind of sense of not having a care in the world that sometimes draws people to them. And then they provide also alternatives, right? So they may say, well, you know, if you want the sense of euphoria, which is why sometimes people will use drugs, here are other things that can provide similar positives without having to use the drug. So depending on what age group they're talking to, whether it's elementary school kids, middle school kids, high school kids, college, they even go to colleges and universities and talk to the students there. They provide developmentally appropriate and candid education to the student. And they also monitor the usage rates for young, like for children as well. And they found that just based on the trends in the country, the age of onset, well, drug use has gone down in general, but the age of onset of drug use has also gone down. So while people, like kids, were starting to use maybe as early as, I think like 12, 13, now they're seeing that if and when people use, it's typically either in their late teens or early 20s, right? Which if we're talking for 10 years, that person did not use, and many will never use, but if they choose, at least they're not starting it as a child, because then that's that much harder to break that habit if all of their coping mechanisms are using drugs, right, to escape the problems. So they found that when drug use starts later in life, the possibility of helping the person get towards recovery or abstinence is in some ways more achievable than someone who might have started using when they were a kid and never had the opportunity to build their internal coping mechanisms, self-soothing mechanisms. It becomes a little bit more challenging.
I would imagine that even has a great impact on their healthcare system in the long term.
Yeah,
And
absolutely.
so economics again.
Yeah, and the criminal justice system, actually. So one of the times that we went, we had one of the higher like police officials that talked to us. He was involved with this starting from like the 70s, 80s, 90s, right? So now he actually works for Europol, and he was telling us that when they implemented this and um, drug users were not arrested for use, they found that their prisons and jails were at 30% capacity. So instead of over flooding, they found that now they were at 30%, and the police could actually focus on doing the crime prevention things instead of just trying to keep people in jail or trying to manage the people already in prison. Yeah, really mind blowing.
Well, thank you so much, Dr. Sharma. I really appreciate you being here. And the couple of people have said thank you so much. They're on their way to their next meeting. Yep.
Okay.
So thank you for being with us, and thank you for coming to the webinar. And I will get certificates out shortly.
Yeah, that's good. Thanks again for the invitation.
Thank you so much.
Bye.